Hi, my name is Kathleen Viveris, and I'll be speaking to you today on hepatitis B and C. Here are my disclosures. I'm going to go through our learning objectives, and then this lecture will be a case-based lecture of 4 cases, and then I'll summarize what we've reviewed. So the interpretation of serology in hepatitis B patients is very important. I'd like to also review the indications for screening in viral hepatitis, to categorize patients with viral hepatitis who are at risk for hepatocellular carcinoma, and to define indications for screening and treatment of hepatitis C. I will not have time to review when to initiate hepatitis B treatment based on AASLD guidelines, but they are listed at the end of my talk for you to review. And also, I will not be able to review all the medications that we use to treat hepatitis B and C. So case number 1, a 34-year-old dentist is seeing you as a new patient. She is starting her job at a local dental school. Employee Health states that she tested positive for hepatitis B. She's confused by this news since she was vaccinated at the time of immigration to the US from the Ukraine. So what labs should we check to confirm her hepatitis B status, and is this recommended by AASLD guidelines? The AASLD stands for the American Association for the Study of Liver Diseases. Hepatitis B surface antigen, hepatitis B surface antibody, hepatitis B core antibody, hepatitis B DNA, or all of the above. I'll let you think about that as we move on. So in the United States, who do we screen for hepatitis B? It's important to remember that hepatitis B is more likely in the US in immigrants from high or intermediate prevalence countries. And by high, we mean greater than an 8% surface antigen prevalence within that country, or intermediate, which is 2 to 7%. Also, US-born individuals, but whose parents are born from high prevalence countries, household contacts of those with hepatitis B, and those with high-risk behaviors. So when counseling patients and discussing who to screen, you should think about how good your geography is and ask patients where you'd like to take your next vacation. So this is a map furnished by the CDC, and I'm going to highlight the light blue areas where there's less than 2% hepatitis B surface antigen prevalence across the globe. Basically, everywhere else is considered high or intermediate, with high being the dark blue and intermediate being the medium blue shades. So again, talking to your patients and figuring out where they would be traveling, where they're born, or where their parents are born is important in considering who to screen. And this is a summary slide, again, available through the AASLD guidance document, which again looks at the persons who are born in these high prevalence countries and intermediate countries. These are the countries that we reviewed. And also the persons whose parents were born only in the high endemic countries. And again, this list is comprehensive, but one other thing I would like to highlight, which we'll review in a moment, is the people who you screen, who end up screening negative, are asterisked, and also these are the people that you should vaccinate. So again, to review the labs in hepatitis B, you have the antibody to the hepatitis B core antigen, the antibody to the hepatitis B surface antigen, the hepatitis B surface antigen, which is a marker of infection, hepatitis B e antigen, the antibody to the hepatitis B e antigen, and hepatitis B DNA, which is the virus level actually detected in the blood, measured in international units per ml. Remember that the hepatitis B diagnosis of chronic infection is established when your surface antigen is present for greater than 6 months. So I'd like to review the interpretation of labs in hepatitis B because I feel this is important clinically and potentially something that could come up. So if you have a screening test result of a surface antigen that's positive, the antibody to the core antigen that's positive, and the surface antibody that's negative, how would you interpret this result? This is someone who has chronic hepatitis B. Again, their surface antigen is positive and their core antibody is positive, meaning they've been exposed to the virus. This is someone who you would send to hepatology for further management, and they obviously would not need vaccination because they're actively infected. If they're surface antigen negative, but core antibody positive, and also have a surface antibody that's positive, they have been exposed and they've resolved infection. Again, this is not someone that you need to send to hepatology. However, if they are on immunosuppressive medication or about to undergo chemotherapy, it's important to involve hepatology in those cases to prevent reactivation. They also do not need vaccination because they have a surface antibody. Hepatitis B is surface antigen negative, the core alone is positive, and the surface antibody is also negative. This is always a little bit challenging for some, but it may indicate past infection with a possible surface antibody that's not being generated, a current infection where the surface antigen is not generated, or a false positive. This is a situation where checking the hepatitis B DNA would be helpful, and you may also want to send this person to hepatology to help you distinguish what the status of their hepatitis B is. They may or may not be someone you would vaccinate for hepatitis B depending on those results. If their surface antigen is negative, their core antibody is negative, but their surface antibody is positive, then this is someone we encounter frequently who has been immune by vaccination. This person does not need to be managed by hepatology, and they do not need vaccination because they have already been vaccinated. And lastly, if they're negative for all three when you're screening, this is someone who is not immune and also uninfected. They don't require hepatology consultation, but they should be vaccinated, especially because you're screening them for hepatitis B. So what should we check? Well, the AASLD recommends that you check for hepatitis B surface antigen and the surface antibody when screening for hepatitis B. The antibody to the core antigen is a single lab test that can also be used, but if it's positive, you will need to secondarily check either the surface antigen or the surface antibody to establish what their status is. Personally, what I check is all three at once for screening because it obviates the need for patients to come back a second time, and that includes the surface antigen, the surface antibody, and the core antibody. Again, just a reminder, these are the list of patients or groups that should be vaccinated if you screen them, and this was listed on the prior slide. I'm just going to highlight the few that I think are more common. Again, US born, but their parents from a high endemic area, AST, ALT elevations of unknown etiology, those who travel to countries with a higher intermediate prevalence of hepatitis B, and then unvaccinated people with diabetes who are aged 18 to 59 are someone you should consider. The ALT of a man and woman are a little bit lower in regards to hepatitis B management than the ranges you might see routinely in labs. So for men, 35 or higher, or a woman, ALT of 25 or higher would be your guidelines to guide your treatment decisions. There's a new vaccine for hepatitis B that was released in 2018 called Hepatitis and it's very convenient and effective. It's a single dose vial of 0.5 mLs, or it comes in a pre-filled syringe. It's given 1 month apart. So month 0, you give one shot, and then a month later, you give the second. And so there's only 2 shots needed to complete the series, which is highly convenient for patients. The details of the vaccine are listed there. And the data from randomized controlled trials were used by the Advisory Committee on Immunization Practices to guide this recommendation, and specifically the seroprotective antibody levels, which were very high with Hepatitis, 90 to 100% of subjects attained seroprotective antibody, in comparison to Engerix, which was 70 to 90% of subjects only. So if you can vaccinate with Hepatitis, it is a more effective agent. So question 1, a 34-year-old woman who is starting her job at a local dental school and seeing you as a new patient who immigrated from the Ukraine. What is recommended by the AASLD to screen for hepatitis B? Is it the hepatitis B surface antigen and the surface antibody and the hepatitis B DNA, the surface antigen and the core antibody, the E antigen, and the hepatitis B DNA? The answer is A, the hepatitis B surface antigen and the antibody to the surface antigen. Again, these are what's recommended by the AASLD. You could also check the antibody to the core as a single test. However, you would need to check again the surface antigen and the surface antibody to determine the state of the hepatitis B exposure if someone returns core antibody positive. Case number 2 is a 27-year-old man with chronic hepatitis B who's seeing you for the first time. He is not on treatment for his hepatitis B and has no family history of hepatocellular carcinoma, or HCC. He was born in Kenya and was screened for hepatitis B upon arrival to the United States at age 20. He has no other history. He drinks one beer every 6 months, and his BMI is normal range at 23. The labs are listed below, highlighting an ALT of 12, a DNA of 3,400. He's surface antigen positive, again, not surprising because he's chronic hepatitis B, and he is also E antigen negative. So he's immune active chronic hepatitis B, and this is because he has a normal ALT. However, his DNA is slightly higher than what we would consider to be inactive, with a DNA of greater than 2,000. His is 3,400, and he's E antigen negative. He has no signs of liver decompensation. He's a young man. He has no family history of HCC, and he's vaccinated against hepatitis A. So what are the things to consider in managing his hepatitis B? His alcohol use. Does he have a secondary risk of liver injury through alcohol? In this case, no, he drinks very rarely. His weight or BMI. Does he have a risk for non-alcoholic fatty liver disease in addition to hepatitis B? Again, in this case, I would say no, given his normal BMI. His HCC risk. He has no family history. He is young. However, he was born in Africa, so let's consider that factor. Here are the guidelines for HCC screening in hepatitis B patients. First, if the incidence of HCC is greater than or equal to 0.2% per year, the recommendations are that you should screen for HCC. In patients with hepatitis B who have cirrhosis, of course, you would want to screen for HCC, just like you would with any patient with cirrhosis. If there's a patient who you're seeing with a first-degree relative of HCC and hepatitis B, these are people who are at higher risk. If they're surface antigen positive and have high risk, and that's considered any Asian or Black man over the age of 40 or an Asian woman over the age of 50, they are considered at higher risk for HCC and you should screen them. And Africans greater than the age of 20 should also be screened, as well as patients with hepatitis D. So he was born in Africa, therefore I would screen this patient. And the reason is that there is a synergy with hepatitis B and a dietary aflatoxin that's very common in many African countries. And this aflatoxin is a inducer of mutations in the tumor suppressor gene, P53. So synergistically, along with the HBV, this can increase the risk of HCC. So how do we screen for HCC? We use serum alpha-fetoprotein and ultrasound every 6 months. In the past, this may have been confusion regarding this topic. However, the guidelines recommend this because there's insufficient evidence for or against the addition of AFP every 6 months in screening algorithms, so they've decided to include this. In areas where the ultrasound is not available, it's also important to know that you can use AFP every 6 months, and that should be performed as your method for screening for HCC. So question 2, a 27-year-old man with chronic hepatitis B is seeing you for the first time. He recently moved to the area and is not on therapy for his hepatitis B. He's healthy, his ALT is 12, his DNA is 3,400, he denies any liver decompensation, and his appointment for hepatology is coming up in 3 months. What testing would you order to screen for for HCC in this patient? His alpha-fetoprotein and ultrasound every 6 months, his alpha-fetoprotein and ultrasound yearly, an alpha-fetoprotein and ultrasound yearly, given that he is less than 40 years old, an alpha-fetoprotein every 6 months with ultrasound yearly. A few moments. Hopefully this one's an easy one for you. It's alpha-fetoprotein and ultrasound every 6 months. As I mentioned to you in a few slides before, there's no indication for yearly ultrasound in screening for HCC. Ultrasound should be performed every 6 months. And again, although there's been some controversy in the past, the recent guidelines support the use of alpha-fetoprotein to help screen for HCC in populations, specifically when ultrasound is not available. The dietary aflatoxins in patients who are in the less than 40 age range from Africa make HCC screening important in that group. Case number 3, a 24-year-old woman with a 10 out of 10 headache, chills, and gum pain 4 days after a tooth extraction presents to the ED. She was given clindamycin, acetaminophen, naproxen, and discharged back to her drug rehab/recovery program, where she has been for 2 weeks. Her labs in the emergency department: AST was 791, ALT was 1,244, alk-phos was 250, her total bilirubin was normal at 0.7, albumin was 3.4, and INR was 0.9. In the emergency room, she had an ultrasound which showed her liver to be normal size and normal contour. There was no portal vein or hepatic vein thrombosis. Additional history was obtained, and she last used intranasal cocaine 3 weeks prior to her presentation to the emergency room. She's been on no new herbal supplements, and she's adopted, so she has an unknown family history. She returns to your office 3 days later for her post-emergency department follow-up, and she also has labs. So on the left are the labs in the emergency room, and then 3 days later in your office, her AST and ALT are declining with an ALT of 744. Her total bilirubin is still within normal range at 0.4, and for the most part, her INR is unchanged. Other additional labs that hopefully were checked in the ED all the time, but were fortunately checked in this time, are hepatitis C antibody, and that turned out to be positive. It's important to remember to look for past values, and it was negative the year prior. In addition, don't stop there. She also had hepatitis C viral load of 234,567 international units per ml. So this patient has acute hepatitis C. It's the highest incidence of hep C, which is acute, is among patients who are 20 and 39 years old, and that's due to increased use of opioids in the epidemic in this population. It's really important to document any history of previous serology to make the diagnosis of acute hepatitis C. And fortunately, only 20 to 30% of newly infected patients with hepatitis C will experience fatigue, abdominal pain, poor appetite, or jaundice like this patient, which means a majority of patients, about 70 to 80%, in contrast, will actually have no symptoms. And it's thought that the patients who do present with jaundice and very, very elevated liver enzymes and present like this patient does is due to the immune response that triggers an intense inflammation. So in acute hepatitis C, the question remains, treat or not treat. And this has been something that's actually recently changed on guidelines within the past year. So I do encourage you to look at this website, hcvguidelines.org. It's sponsored by the AASLD as well as the Infectious Disease Society of America. It's a living, breathing document that is your number one resource, number two resource, and three resource for hepatitis C information, both in clinical management of patients and then also perhaps to study for any examinations. So based on these guidelines, what we do now is actually treat acute hepatitis C, which again is very different than last year. So the recommendations encourage people to check the hepatitis C antibody, and then if positive, the hepatitis C RNA. And if the RNA is detected, you treat. And this is someone that you would refer to hepatology for discussions regarding types of treatment, especially if they're jaundice. You definitely want to refer them to hepatology to have them be closely watched and managed. You will need to check their hepatitis C genotype and also assess in some way for cirrhosis before treating patients for hepatitis C because it will influence the regimens that potentially are selected. And again, this is something that's clearly an issue with some clinical encounters with patients. Please note that the hepatitis C can spontaneously resolve in about 20% of patients. So if you do check a hepatitis C antibody as a screening mechanism, which is recommended, you should definitely check the viral load if the hepatitis C antibody is positive. This will definitely help patients alleviate a lot of their concern and anxiety prior to the visit if the hepatitis C viral load is negative. In chronic hepatitis C, again, I reference the HCV guidelines. Key points that I want to highlight are there are many treatment options that exist for a variety of unique scenarios, including dialysis, patients with cirrhosis, those who have prior treatment and who did not succeed in attaining SVR, etc. There are pan-genotypic options, meaning you can use one drug to treat any genotype, and those to highlight are sofosbuvir, velpatasvir, or glecaprevir and biprentasvir. The choice really is determined by patient's insurance. The length of treatment is 12 weeks for sofosbuvir and velpatasvir or Epclusa, and 8 weeks for glecaprevir and biprentasvir, which is Mavyret, respectively. If there is severe renal impairment or a dialysis patient that you're dealing with, glecaprevir and biprentasvir is the choice. Treatments are all pill-based, so either 1 pill per day or 3 pills per day. are going to be the choice that you review with your patients, and that depends on the regimen selected. And the most common side effects to review with patients are headache, mild nausea, mild fatigue, but in truth, most patients complete their full course of treatment without stopping, and it's very, very manageable and tolerable. The efficacy is superb for all of these agents. I usually quote a number of about 95% or higher for a sustained viral response, regardless of which regimen you use. It may even be higher than that, but I never want to say 100% for patients because it's not always that every patient responds. SVR is defined as a viral load that's undetectable 12 weeks after completing therapy. So only then are patients considered cured of hepatitis C. And it's really important to check the hepatitis B status of patients that you're considering to treat for hepatitis C because there can be reactivation with the direct acting antiviral agents or the DAAs. So question 3, a 24-year-old woman presents with an ALT of 1,244, recent intranasal cocaine use. Her ultrasound of the liver reveals a normal contour and normal Doppler flow. What tests are needed before treatment of her suspected hepatitis C? Hepatitis C antibody, hepatitis C RNA, a FibroSure test, which assesses for fibrosis, and hepatitis B serologies, hepatitis C antibody, hep C RNA, hep C genotype, and hep B RNA, hep C antibody, a FibroSure, and hep B RNA, hep C antibody, hep C RNA, hep C genotype, and hepatitis B serologies. So hopefully this one was a little bit easier. Hepatitis C antibody always is followed by the RNA, and you do want to check their genotype before treatment and also get hepatitis B serologies. Again, reminding you that 20% of patients may spontaneously clear the virus, so you always want to check an RNA. The genotype, again, is important in the regimen selection, and you want to make sure you know their hepatitis B status. The hepatitis B is a DNA virus, so B and C are wrong for that reason, and answer A is incorrect because you do have an ultrasound already that demonstrates no evidence of cirrhosis, so FibroSure in this case would be unnecessary. But if you answered that, that's good thinking. Case 4, and our last case, is a 45-year-old woman who was born in Cape Verde in Africa and is seeing you for diabetes, which was newly discovered during a hospital admission for cellulitis. She also has fatty liver and elevated liver enzymes with an AST of 45 and ALT of 56. You perform routine health maintenance and screen for viral hepatitis given her elevated liver enzymes. So which type of viral hepatitis would you initially screen for in this patient coming to your office? Hep A, B, C, D, and E, Hep A, B, C, D only, Hep A, B, and C, or just Hep A and B? Well, we don't usually screen for hepatitis E as a chronic cause of elevated liver enzymes, which this patient likely has, so we don't check that one. Hepatitis D is only important if someone is known to have hepatitis B, so we don't routinely initially screen for that. And the choices are between screening for hepatitis C or not. And the answer is actually C in this case. And this is also a new recommendation within the past year, which is that now, given all of the therapies that we have for hepatitis C, which are so effective, we actually screen all patients for hepatitis C, and that is a universal recommendation, regardless of risk factors, regardless of whether they're born in a certain country, regardless of whether they've ever used drugs, regardless of any tattoos or any piercings or anything that you've ever known to check for hepatitis C, we screen them all. So with that emphasis, here's our question. A 45-year-old woman with chronically elevated ALT of about 56, diabetes and fatty liver comes to you. How would you screen this patient for hepatitis C? A hepatitis C antibody and a hepatitis C viral load. B, the hepatitis C antibody, the viral load, and the genotype. C, no need to test for hepatitis C since she's not at risk. Or D, use only the hepatitis C antibody. The answer is D, only the hepatitis C antibody to screen. C is incorrect because, again, as I mentioned, CDC guidelines just recently recommended within the past year that hepatitis C screening should be universal in all patients greater than 18, regardless of their exposure risk, given the new effective direct acting antiviral therapies that are highly effective and safe. The antibody testing is also recommended of note in all pregnant women. Again, we only check the antibody first as a screening mechanism. We don't do all of the other tests, although these other tests, such as the genotype and the viral load, will be important before treatment of hepatitis C. So in summary, hepatitis B should be screened for in many patient scenarios. Vaccination for hepatitis B is likely indicated in many of the patients that you encounter in a clinical setting. There is new hepatitis B vaccination that's available. It's a series of 2 doses, 1 month apart, and highly effective. HCC, or hepatocellular carcinoma screening, should be performed in high-risk patients. Ultrasound and AFP every 6 months should be the modality used for HCC screening. Acute hepatitis C is now treated when diagnosed, and that is a change within the past year. HCV screening should be done universally in all adults greater than the age of 18, regardless of risk, and that is a change. And hepatitis C should be checked initially when screening for hepatitis C. Thank you for your attention. These are some of the references that I used, and again, these are the guidelines to look for treatment guidance in hepatitis B and also HCV guidelines if you have questions regarding HCV. Thanks so much.